for joining us for this week's edition of Seven Habits of Long-Term Care Programming. This week, we are going to talk about reason for referral. So reason for referral really is the piece, and to echo our call from earlier, if you guys were on the big therapy call, it ensures that you understand what you're assessing and why the patient requires therapeutic intervention. So really, this is our point, our jumping off point to show that we know why we're picking this patient up, and it's guiding our evaluation process from this point forward. So this is really where we're planting our flag for our whole plan of care. So it's kind of one of those pivotal moments where we're showing that we understand the skill that we're going to provide. If you look at the tool that we passed out on week 1, the questions to ask about therapy documentation, these are the items that we've included on that tool. So the first thing that we're looking at is who is referring this patient for care, or where did the referral come from? So maybe it's nursing, maybe it's from a report that we've pulled, maybe it's from another discipline. Wherever that referral, maybe it's a physician, and for outpatient, a lot of times this piece is a little bit easier because we're getting referrals from those outside physicians. But it's the who piece of where we're getting this referral from and why we're looking at this patient to begin with. The second piece that we want to ask ourselves is, what is the medical and or functional presentation of the patient that's relevant to the referral? And is there corroboration of that in the medical record? This is the piece that sometimes is a little bit more difficult for our outpatients because we don't always have that medical record going into it. So it's super important that we're putting the why behind what really has been the catalyst for this referral. For our folks that live with us, we should be able to really dive into PCC for these pieces to show what's changed with this resident, what's different, maybe what has failed when we've tried to pass off things to other caregivers. And we'll talk a little bit more specifically about skilled maintenance here in a minute. And the last question that we want to ask is, and this piece is one that I see over and over that we kind of need some more conversation about. If we have a patient that was recently discharged from therapy services and we're picking them back up again, is it clear to the person reading that evaluation what changed as to warrant that readmission to therapy services? Some of the common pitfalls we see, I know a lot of us have really been involved in doing a lot of chart audits recently and digging into some documentation. Some of the things that we see fairly commonly is that we're being a little bit too generic on these pieces. For our skilled patients, one of the things that always kind of makes you shake your head a little bit is the referral is they were admitted to the hospital. We really want to make sure we're being more specific about why are we picking this patient up on this discipline at this time. Or maybe they admitted from home to the facility. It still really doesn't tell us why we're picking up this patient. Another thing that we see fairly commonly that we really need to avoid is that we're transitioning to skilled maintenance. I think sometimes we get in this habit of we think that just transitioning those programs is a cause for a new evaluation. And although it may be, we really need to use this opportunity to explain the why. Why are we doing a new evaluation for this patient? Why do they need that skilled maintenance service? The other thing that sometimes we see is we're evaluating due to payer change. Although we do know it's best practice if we have a payer change. Can you mute whoever just came in?
Oh,
Thank you. We do know, thank you. It's best practice to do a new evaluation with the payer change. We still need to put at this point the reason for the referral. And maybe it's the same reason that we had them on caseload under a previous payer, but we can't just put new payer change and that be our reason for referral. So we still want to make sure that we're putting clinical information in this piece. The other thing that we see is that sometimes we're not taking the opportunity to refer back to any changes that were noted in PCC. So kind of that, what's our cooperation in the medical record? If there's weight losses, infections, falls, changes in the ADL function, behavioral changes, things like that, this is a really great opportunity to put that information in to really justify why we're looking at this patient to begin with. And then again, we kind of talked about if the patient was recently discharged from skilled therapy services, we really need to pay extra attention to justify why we're readmitting them into therapy services again. There's nothing wrong with picking a patient back up again. We know when there's a change, we don't wait for a prescribed amount of time. We pick the patients up when they need our services. But we do need to be mindful that we're really putting the why behind we're picking this patient up at the time that we're picking them up. So the thing I'm asked for most often, and the thing that we hear a lot is show me some examples. What are some good examples of reason for referral? And again, we're going to send this out to you guys, so you don't need to worry about trying to scramble to take pictures or copy it down. It's a lot of words on a screen. But I really wanted you guys to have some good examples of what this reason for referral can look like. We did put a few skilled maintenance, and I'll go through and show these to you guys, but there's a few different kinds of reason for referral on here. There's some good verbiage. I think one thing we do need to remind ourselves of that was mentioned on our big therapy call, no matter how great the words are, if you use the same words on every single evaluation, they cease becoming skilled. So if it's copy and paste, it doesn't matter how great your words are. We really need to make sure that it's patient specific. But these are some really good examples of all the information that needs to be included on there. The why the services can only be delivered by a skilled licensed therapist, things like that. Again, I won't read these to you guys because we're going to make sure you have these samples in your hands. And then more specifically, abilities care approach. I had this question right after our call last week because sometimes these folks aren't necessarily having changes that are precipitating our evaluation. I did pull this off the portal. This is from one of the items on the portal under abilities care approach programming that has different sections of the evaluations and samples there. So if you want references as to where I found this, just reach out and I can get that to you as well. But these are just some good examples for reason for referrals. They're not quite as wordy. So again, I think it's important to understand more words doesn't necessarily mean your documentation is better. It just means you have more words. So some of these are pretty concise and to the point, but they still capture the essence of why we're picking this patient up. And that's it. So that is just kind of in a nutshell, that reason for referral. Again, if you guys have questions, we'll stop recording now. We can push that magic button.